The technique of immediate stabilization or loading is a reliable and convenient chairside treatment with the Bicon implant system. Further to the normal principles of implant placement, the immediate stabilization technique requires only one additional criterion: the ability to prosthetically immobilize the implant with a transitional stabilization prosthesis. Successful osseointegration is not dependent upon the density or quality of bone to provide initial stability of the implant in its osteotomy. Implants placed immediately after an extraction, or even after a ridge split osteotomy, are excellent candidates for the immediate stabilization or immediate loading technique. This technique is applicable for a single implant or for a full arch of implants. Bicon shouldered abutment and one-piece acrylic sleeves are the essence for fabricating an effective chairside transitional stabilization prosthesis. These components, in conjunction with a variety of transitional materials such as Integrity by Densify, Connect, a Kevlar ribbon by Kerr, and Diamond Crown, a polyceramic material by DRM, provide for the fabrication of timely and cost-effective chairside stabilization prostheses. After the placement of an implant, the immediate stabilization technique began with the selection of the appropriate shouldered abutments. A shoulder depth gauge was seated into the well of the implants to indicate the height of the seated abutment shoulder relative to the crest of the soft tissue. The width of the selected abutments was dictated by the anatomy of the interproximal papillae. The papillae should be supported but not encroached upon by the transitional stabilization prosthesis. Similarly, the selection of the width of the appropriate one-piece acrylic sleeves was dictated by the interproximal papillae. The height of the one-piece acrylic sleeves was dictated by the occlusal clearance. The sleeves are modified buccally to accommodate the vacuum-formed template. Adjacent natural teeth were prepared for the bonding of the transitional stabilization prosthesis. Transitional composite material was added to the acrylic sleeves to form a strut. Additional composite material was added to the occlusal aspect of a vacuum-formed template prior to its insertion over the strut. The prosthesis was removed for polishing. Prior to bonding, the transitional stabilization prosthesis was snapped onto the shouldered abutments, which were seated with only finger pressure, for confirmation of its morphology. After being bonded, the prosthesis should be evaluated in 2 or 3 days for stability. The patient should be admonished to carefully monitor its stability as though it were a cast on a broken limb. "11 weeks later, the transitional stabilization prosthesis was removed along with the shouldered abutments. The implants were evaluated for stability. A white impression post was tapped into the well of the implants in order to make an implant level transfer impression. The transitional prosthesis was reinserted while the permanent restoration was fabricated. On the patient's third clinical visit, 2 integrated abutment crowns were inserted. The restoration of an edentulous maxilla in only 3 clinical visits within 100 days clearly demonstrates that the technique of immediate stabilization or loading is a reliable and convenient chairside treatment with the Bicon implant system. The technique is essentially the same as if it were the immediate stabilization of a single implant. After the placement of the implants, a shoulder depth gauge was inserted into the well of the implants to indicate the height of the soft tissue relative to the implants, which facilitated the selection of abutments with an appropriate shoulder height. The appropriate shouldered abutments were placed with only finger pressure into the well of the implants. 1-piece acrylic sleeves were snapped onto the abutments prior to their being connected with a transitional composite material to form a strut. The strut was modified to accommodate a vacuum form template. Additional composite material was injected into the template prior to its being inserted onto the strut. After polymerization, the prosthesis was removed for contouring adjustments and polishing prior to its being snapped or cemented onto the shouldered abutments. At the completion of the first clinical visit, the occlusion was adjusted and the patient was admonished to carefully monitor the stability of the prosthesis as though it were a cast on a broken limb.